Yeah, hello, wonderful people. There's Frank again, and today we're doing using the care plan, part 4. Using the care plan, part 4. Today we're going to be looking at how we'll use the problems from the last video to form our nursing diagnosis, and then the others that will accompany them. But first of all, as usual, let's go to our motivation for the week. Charisma. The first impression can seal the deal. Yes, when you are charismatic, the first impression can seal the deal. When it comes to charisma, the bottom line is other-mindedness. Leaders who think about others and their concerns before thinking about themselves exhibit charisma. That's by J.C. Maxwell. Well, so now we pick anxiety. Patients anxious due to hospitalization. What can we do for the patient? So, as part of our outcome criteria, what would we want for the patient? So we say patient's anxiety will be relieved within 24 hours. How do we see that? As evidenced by a relaxed facial expression of the patient. So there are many ways by which we can state this. You can try yours at home and give me a shout out if necessary. So, first, with the others, we have to reassure the patient that every care will be taken to ensure his quick recovery. Again, we need to explain the need for hospitalization to the patient so that when he understands, it will lessen his anxious state. We allow patients to verbalize feelings of fear. Inform the patient and explain every procedure to the patient before carrying it out. And that is very important. Then allow patients and relatives to ask questions and answer them tactfully. We also encourage relatives and significant others to participate in the care of the patient so that the patient will feel at home. And then we can serve prescribed anxiolytics. So for anxiety, if we do these things, we are going to relieve the anxiety. Okay. Self-care deficit. Self-care deficit. So we want the patient to be able to care for himself or be helped care for himself. So we say patients will be able to perform self-care activities within 72 hours, as evidenced by a patient being able to perform self-acts with little support. We can put that also in several ways. So you try hands on that and leave it to me there and we'll look at it. So we can reassure patients that hygiene needs will be taken care of. We bed bath patients twice daily. We teach the patients to use affected extremity to accomplish use unaffected extremity to accomplish tasks. We assist. We don't do for, we assist in grooming and dressing so that the patient will be able to do some of the activities himself so that he can gain the ability to perform self-care activities. We perform oral care twice daily. We serve bedpan when needed, perform pericatus care regularly, and encourage patients to participate in care. That is very important, to participate in care, so that the patient's self-care deficit is being taken care of, and also will help patients to be able to partake in the self-care activities. And then we need to document procedures. Constipation. What can we do for the patient? So patient will be able to move bowels within 12 hours, as verbalized by patient that he has been able to move bowels. So, first of all, we reassure the patient that he will be able to move his bowels soon. So what are some of the things we do? We have to encourage passive exercises, and then encourage patients to take in a lot of fluids. Advise patients to take high fiber diets such as oats, and then we serve warm bedpan, and then we document procedure, of course. So in doing those things, and then we have to serve prescribed drugs to help move bowels. Serve prescribed drugs to help move bowel. So in doing those things, we can help achieve movement of bowels. How about impaired mobility? Patient's mobility will improve within a week, as evidenced by patients demonstrating the use of adaptive devices to increase mobility. And then patients being able to move affected limb progressively within 2 weeks. So for this, also we reassure the patient that he will be able to lift affected arm and leg in a few days. So, as one of the things we do for his patient, we place orange in the palm of the patient and encourage the patient to squeeze. As he squeezes little by little, he gains the strength. We instruct patients to try and move arms and legs slowly. We also have to assess symmetry, strength, and degree of mobility of the patient. And we ensure that passive range of the motion exercises as ordered by a physician for early to affected limb. So you try to move the arms and the legs affected maybe every 2 hours or every 4 hours as ordered by a physician. And then position in proper alignment and reposition every 2 hours. And then we encourage isometric exercises when indicated. We also check or teach proper use or function of adaptive equipment, and then we document procedure. Impaired skin integrity. Now, we don't want the patient to have impaired skin integrity due to immobility. So what do? First of all, patient skin integrity will be maintained during period of hospitalization, as evidenced by patient skin being free of bed sores. So we don't want patients developing any bed sore. So first of all, we inspect and chart skin integrity every 12 hours. We reassure patient that his skin integrity will remain intact. We keep patient's skin dry and free from pressure. We tend patient every 2 hours. We treat pressure areas. We straighten the bed linens. We change soiled linen immediately so that we don't have any bed sores. And then we maintain adequate nutrition and hydration. And of course, we document procedure. Sleep pattern disturbance. We want the sleep pattern to improve. So patient's sleep pattern will improve within 24 hours, as evidenced by patients being able to sleep 6 hours uninterrupted. So, we reassure patients that sleep pattern will return to normal, reduce noise level in the ward at bedtime, we ensure adequate ventilation, we give warm bath before patient retires to bed, we straighten bed linen, we serve warm beverages at their bedtime, some warm milk, it's fine, maintain bedtime rituals, we serve prescribed sleeping pills like diazepam, and then we document procedure. And then impaired speech. So, patients will be able to communicate within 72 hours, as evidenced by patients demonstrating improved ability to express self. People may argue that 72 hours is too short, but it lies with you. So depending on how bad the impairment is. So for this, we're taking 72 hours. So you reassure patients that speech will improve with time. You listen attentively when patient speaks. Maintain eye contact with patients when communicating. Teach patients how to use gestures and other forms of communication, such as picture, bell, word board, flashcards, or translate words or phrases. Validate patient message by repeating aloud. Use short, repetitive directions. Ask simple yes or no questions, and document activities. So, for this, we can also maintain patients' self-expression, as evidenced by patients being able to communicate with the nurse. That's all as another way you can put the outcome criteria. Altered nutrition. Patients' nutritional status will be maintained during period of hospitalization, as evidenced by patients being able to consume about 2/3 of all meals served. So we assure the patients that all efforts will be made to ensure adequate nutrition. We plan diets with patients. We serve bedpan prior to feeding. Ensure mouth care prior to eating. Serve food attractively and in bits. Place patients in comfortable position before feeding, and allow patients more time to chew and swallow food. And of course, document your procedure. Alteration and body comfort. Patients will be comfortable within 30 minutes, as evidenced by patient verbalizing absence of headache. So, we reassure patients that he will be free from pain. Assess characteristics of pain, the location, the severity on a scale of 1 to 10, the type, the frequency, precipitating factors, and relief factors. We eliminate factors that precipitate the pain, such as noise, etc. And then we assist patient to assume comfortable position. We apply cold compress to the head. We administer prescribed analgesics. and then we document activities. With knowledge deficit, patients will have adequate knowledge about disease condition within 30 minutes, as evidenced by a client being able to state causes, signs and symptoms, management, prevention of disease management and prevention of disease condition. So 30 minutes may not be right, but let's say in about 2 hours we'll be fine. So we reassure patients that his condition is curable. We assess patients' readiness to learn by assessing emotional response to illness, acceptance, anger, anxiety, denial, etc. So we assess the emotional response. We also allow patients to work through and express intense emotions prior to teaching. We assess preferred learning mode, either auditory, whether group learning or visual, etc. We assess literacy level. We ask patients about his knowledge on the disease, cause of disease. We use simple language to educate patients on cause of disease and condition. Present most significant material to the patient first. Introduce patient to other patients who have recovered and are in similar condition, and ask patients for feedback to assess level of understanding. Some of these others we may not be able to do for our patient who is sick, but they are here to just broaden the horizon. So today we've taken so much time, but we'll end it here and we'll further look at that in the next video. Thank you. Bye bye.